So thank you, sir, for this nice introduction. Good afternoon, everybody. So I don't have much experience in utilizing very elderly and living donor, but whatever we have experienced that we'll discuss and discuss on three parts: whether how much it is risky from the donor's point of view in terms of future development of the ESRDs, death, post-operative complications, surgical complications, and also in the patient's recipient's perspective in terms of their graft and the patient survival. So you know, CKD is increasing everywhere all over the world, and it is a genuine problem, and one of the causes of death in the first 10 causes. And this is the projected death rate of the ESRD patients all over the world in the 2040. It will be pretty high all over the world, including India. And burden of India is very high. You have a huge population, and so going to be very high. And the death due to ESRD or CKD stage 5 is also very high. It is slightly different from state to state, but it is still high. Options left: dialysis, transplantations. Obviously, transplantations is a better option compared to dialysis in terms of the patient and the graft survival. May it a disease donor transplantation or living donor transplantation, it is always better keeping the patient on hemodialysis or any kind of dialysis. But there is a huge gap between the donor and the recipient, and there is to overcome that is not only for our country, it is everywhere. You can see even in the USA, after 3 years, only around 45% of the patients in the waiting list get a kidney and get transplanted from both including the disease donation as well as the live donation. So what may be the solutions? Already everybody has discussed by this time. I was late a bit. So one of them is expanded criteria for the donors and inclusion of the elderly donors. In our center, we are mostly doing ABO incompatible in place of this elderly donor. We don't include very much because of several reasons. So if you see what are the causes of the kidney discard, old age is one of the important thing. Kidney is denied even in the living donations because of history of diabetes, HCV infections, drug abuse, cardiac issues, and so many things: proteinuria, stones, obesity, cysts, etc. But one of them is an old age. And in our center, we usually don't, we are not discuss about the kidney donations if the donor is more than 70 years of the age. It is maybe after this discussion and after this discussion in an August gathering, we may be, my outlook or our outlook may slightly change. So age is an important cause of denial of the kidney. So why it is so? Why is the aged kidney is denied as a kidney donation? Because with age, kidney decays, GFR reduced, and the kidney filtration function reduced. At the same time, due to senescence, the immunogenicity increases. So if you get a kidney from a very elderly donor, chances of rejection, whoever you are putting in the kidney, chances of rejection is higher. So is a low functioning kidney with a more immunogenicity is actually the best, in the back of our mind, is the main cause of denial of a kidney from an elderly donor. So with age, how kidney behaves, actually, if you estimate the GFR by using different formula, it is quite linear. After a certain age of time, there is a reduction of the GFR, but if you measure in terms of the creatinine clearance, in those cases, that may not be that linear. And if it is so that we average in 1 decade, we lose 7.5 ml of GFR. Why? If you estimate the GFR, that means because 1/3 of the patient, if you measure the GFR, this linear relationship is not there. Many of them actually preserve GFR. Some of them even increase the GFR with age because maybe associated diabetes, maybe associated obesities and other comorbidities which actually causes an hyperfiltration. So healthy kidney versus aged kidney. So if there is nothing happens, is a linearly patient is aging, there is an increase in the decrease in the GFR, that is not considered. Certain differences in patients having CKD with it, that I am not going to discuss in terms of presence of IFTA, in terms of presence of an hyperfiltrating glomerulus, in cases of in the tubulointerstitial changes. So whenever, what are the determinations of the evolutions of the kidney functions with age? Actually, kidney decays with the certain determinants depending upon the age, other than age, it is sex. Male may have a higher GFR, but with time they lose the GFR much faster rate compared to the females. If the patient is obese, and wherever there is an albuminuria, there is a more chances of loss of GFR. It may be more in compared to the patient who doesn't have any microalbuminuria, the increased ACR. So there is always a trajectory. You can see there is a loss of GFR and intervening ACR. So you can target the trajectory where you can target the donors and get it safely from the patient, from the donor's point of view, and you can get and the chances of development of the ESRD in the donor is much less in those cases. So we have to target those trajectories, not only taking an aged donor. This is one line comment, or the patient having other things like a microalbuminuria or the obesity or the hypertension or the diabetes, but there is an intervening trajectory that may give us a kidney that may last longer and be safer in terms of the patients. So whenever you are donating an organ, what are the risks related to this elderly living kidneys? Because it is not a disease donation, it is a living donation, you have to think on the both sides. A 72 years father, he wants to donate his son, 50 years son, and what are the things they will ask in terms of the patient, how the kidney will work, at the same time what will happen to the father. So in those cases, you can see what happens when the donor nephrectomy is done. There is a sudden loss in the GFR. In the next 1 to 2 years of the time, there is slightly increase in the GFR. After some time, there is a plateau, neither it decreases nor it increases. Even there is a hyperfiltration injury, that is common factor in oligonephronia or a low nephron mass, and that doesn't happen after the donor nephrectomy. This is normal. After 5 years, hardly there is an increase in the GFR. If you take, if the patient is, it is the study, important study which showed that according to the age, how much kidney behaves after immediate, after the donor nephrectomy, there is sudden immediate loss of the GFR. If the patient's age group is very low, that is, and the donor's age group is low, that is 18 to 30, compared to more than 50, you can see in the more than 50 group, the loss is maximum. But even though with this low count, this patient may have a GFR of maybe 78 or maybe 81 or maybe something, there is an immediate loss is maximum, but with time gradually it doesn't decrease. It actually goes up, and it may be slightly more, it may be slightly at par with the kidneys of the slightly lower age group. So there is a fall, but still there is not a progressive fall, and chances of landing up in the ESRD or ESRD is much less. That is same if you see, if the patient who is having a less than 80 GFR, you can see the loss is maximum. You can see the drop is maximum in cases of the less than 80 GFR patients. But even though the loss is maximum, there is gradual improvement, and it can take part. The idea of giving I am giving is that if there is, even though there is a loss of the GFR is high, chances of development of end-stage kidney disease in the donor is much less, even you take an elderly donor. In donors, we are worried about three things: about whether he will develop an ESRD, whether he will develop increased cardiovascular disease, or whether he or she will develop a perioperative complications. So this is another same thing that has been explained in a different way. In a patient, in a donor who is elderly, the loss of GFR is less, but they gradually take up. There is a loss is maximum in elderly patients, but that they don't lose with time. In the similarly, the recovery is also slowest, but they can maintain in that way. You can see if a 40-year-old man having a GFR of 80, they lose a 50% GFR at the time of the nephrectomy, they gradually cope up. That is much better compared to a patient who is 70 years of age having a GFR of maybe 68 and losing half of the GFR, their recovery is much less. But the recovery is slow, remains slow, but it don't decline. So does it affect the survival? So probably yes, if you compare them with the other age group, you can see if you compare between 30 to 50 years or 50 to 70 years, if you get a donor of more than 70 years, the survival is different. Definitely the survival is much lower in the patient's living donor who is donating kidney after the age of 70 years. But this may not be related directly to the kidney donation. It may be due to several reasons. As the mortality is higher above 70 years of the age for any patients, this is an important, this is a very good trial trial which involved more than 1,000 patients, and they were followed in between 2008 to 2020, and there is a 73 months follow-up. And they have shown, although their surgical outcomes are not very different, GFR is not an issue in these elderly donor patients. Development of chances of ESRD is much less, but the mortality is definitely higher in this age group, but it may not be related to the donor nephrectomy directly. So after this, the patient who is elderly and who is wants to be a living donor, you explain them, if we examine you properly, then the chances of perioperative complications are less, chances of developing a end-stage kidney disease are less, but you may have a more chances of mortality, but that is not related to this procedure per se, but it because of this is the mortality is higher in the higher age group. So initial idea from the patient's perspective or the recipient's perspective, if you get an old elderly donor and low GFR kidney, you will have a lesser kidney function, lesser graft survival, and in terms of your survival, graft and patient survival is low if the kidney is low functioning from a living donor. Sorry. And the things has changed. That was in the you can see that is in the 2003, 2004. But the things has changed over the 5 years. It is another publication in 2008. With the development of the newer immunosuppressive and optimization of the drug, advent of this in the induction agents in a proper way, they have showed that even though the donor's GFR is slightly low, and if you take from the elderly patients, the chances of patient and the donor survival is not that low, that bad, and it is much better the patient keeping on a waiting list or patient on the dialysis. So this is another important study that compared these patients who are getting an elderly donor. This is from the European, and there's a Belgian study. They taken the patients from the more than 60 years of the age with or without proteinuria. That may be without proteinuria, and they compared them in terms of their sudden cardiac death, and this is a development of the ESRD, and this is and compared them with the dialysis, and they showed that older patients might gain a survival benefit from the standard criteria transplantation over dialysis, but this if they get elderly patient gets a donor who is elderly, there is a benefit is minimum. This is adult living donor kidney transplantation, donor age and recipient age data. Now one is a donor who is elderly, and now the recipient is maybe a different age group. They have compared the patient receiving elderly donor kidney, that is in the 30 to 50 group, 50 to 70 and more than 70 years of the age. So you can see if the age difference is much more. Suppose the elderly patient is donating a patient to the younger recipient. In those cases, the outcome is much better compared to an older donor and the recipient is also older at the same time. You can see if the age difference is less than 10 to 15, this is the worst part. You can see the lowest line is the elderly donor donating an elderly recipient. That is much worse than elderly donor donating an younger recipients. You can see in terms of survival, it is the lowest line is the older donor to the older recipients. And this is not a living donor, it is almost kind of forest plotting, but still if this is for the disease donation, still it is always better than keeping the patients on hemodialysis. So if you get an elderly donor, you can plan it for whom to you give, how much you can give, assess the risk from the perspective of the donor, benefits from the perspective of the recipient, and you can choose amongst them. And another way is putting this elderly donor. There is a elderly donor this is a paired kidney donation program. There is a discussion of the Dodi Segep was telling he had a patient, a grandfather is 68 years of the age, once, and as a grandson is only 17 years of age, 2.7 creatinine. He wanted to donate his kidneys, and at that time they put him in the pool as an initial altruistic donor, and after that the program started, and he donated the kidney prior hand, and his grandson got the kidney few years after that when he reached the stage of the disease. So this is another way of utilizing these elderly kidney donors in a domino or as a peer donation pool. This is not going. So something we have already, Dr. Raju has discussed, as they are more immunogenic, it's always better to utilize during the transplantations and ATG in terms of inductions. Tacrolimus should be used very cautiously because CNI has a double kind of, it suppresses the development of the rejection, is a more potent immunosuppressive, but at the same time they have a fibrotic effect much more. So mTOR based or belatacept based regime may be utilized for the patients with donor, and different cell based therapies has been tried in the patients with elderly donor that keep the kidney prolonged. We don't have much experiences in those cases. Just I found time to get this is a post-COVID state 3 years back. The transplantation number was around more than 1,000, and age group we considered is a more than 60 was around. This is a more than 60 was around 72 donors, I think, and it considered to be 6% of our overall kidney donations. And the comorbidities were significantly higher in this age group in the terms of hypertension, pre-diabetes or the diabetes, and the DTPA GFR is also slightly on the, as we measured the GFR by the DTPA, it is on the lower side compared to the patients having a younger donor. And there is no increase in the intraoperative complications in this subgroup, so it is reasonably safe to do the surgery in the elderly group. There is no difference in the post-operative complications, immediate post-operative complications. And the post-operative results in terms of the GFR is not significantly different from the patients who are from the younger donors. And if we followed them for 1 year, you can see there is a slightly lower GFR baseline, but still they are comparative. They also gain GFR at the rate of 1 ml per 1.73 meters square like that in per year, and there is in a 2 years time, there is no loss of GFR and no development of ESRD in this age group. So with summary, we can tell elderly donors are a viable option to enlist the living donor pool, and acceptable decline in the CKD can improve the quality and life survival without significantly impacting this one's own well-being, because here in a live donor you have to think both for the donor as well as for the recipient. Thank you.
Thank you very much.